Good evening, everyone, and welcome to today's wonderful evening. Pediatrics, we have been laboring for the past 4 days, starting from the last Sunday. And I'm very sure every day evening, 6 p.m., when we all meet up, you solve 50 questions, and then we have a discussion on those questions. The whole exercise of about 1 to 1.5 hours of interactive session daily. You have Dr. Murali Bharadwaz as your classmate, roommate, benchmate, table mate to study along with you. And this should give you the required inspiration to go back and consume. There is a 427 hours of HD video, 1500 topics on the onlinembbs.com video library covering all the 19 subjects. That will give all the required fundamentals for your preparation. So good, Sai, Kiran, and many more who are all online. So every day, evening, 6 p.m. Just mark it on your calendar. Until the NEET PG exam is over in the March 3rd week, we are going to study together, and we are going to do the revision every day. So let's make a great beginning, Doctor. Yes. Good to see Sai, Kiran, Shailaja, and many more who are all online. Can online students can punch whether the voice is loud and clear for all of you? Yes. Yeah. I hope the voice is loud and clear for all of you. Good to see Siddhaya joining from which part of the country, Siddhaya, are you from? I think from Karnataka. And what is the dream branch of Siddhaya among our classmates today evening? So please punch. Now, cerebellar astrocytomas in the pediatric age group. What do you know about it? They have a good prognosis. They're more commonly seen in the first and second decades. Wow, that's good. Siddhaya is from Andhra Pradesh. Cerebellar astrocytomas are more common in the females. Is wrong. Generally, cerebellar astrocytomas in the pediatric age group are low-grade tumors, is what the good news. So, pilocytic astrocytoma. It is very common in childhood, and it is the most slow-growing of the gliomas. Is the video not clear? Oh, voice is clear, but video is not clear. Okay. Sometimes there is a small issue with the internet on this side. Maybe that could be one of the reasons. Yeah. Yes. Yeah, I hope the internet will not be too prohibitive. So on my side, the internet is a little slow, maybe because of that reason. The voice is clear at least. So cerebellum, around the third ventricle, optic nerve, they are the classical locations where you see pilocytic astrocytoma. Grossly it is cystic, and there will be uh, elongated hair-like cells, rosenthal fibers that characterize the pilocytic astrocytoma. So the pilocytic astrocytoma is 10 to 20% of all the pediatric brain tumors. It is the most common pediatric CNS glial neoplasm. 6 to 8 years is the common age group. And it is rare to see pilocytic astrocytoma below 1 or above 40. And they have a very high survival rate and an excellent prognosis that characterizes the pilocytic astrocytoma is what you need to remember. So this is a low-grade astrocytoma appearing as the grayish-white areas in the cerebellar hemisphere, the classical gross appearance. So what is the cruel variety of astrocytoma? It is a high-grade astrocytoma, which is called glioblastoma multiforme. The most cruel variety. It has got a very poor prognosis, is what you need to remember. Now, what is the diagnosis for a cyst, which is in a child, which is located in the mediastinum and associated with vertebral defects? What is that cyst? It is the neuroenteric cyst. So you should remember, in the mediastinum, you can have esophageal duplication cysts, most commonly in the thoracic esophagus, and they are associated with chest vertebral anomalies. They can lead to paraplegia, meningitis, etc., etc. Then neuroenteric cysts. Whenever there is an incomplete resorption of the neuroenteric canal, it leads to neuroenteric cysts. It occurs in children, adolescents presenting with dysphagia, classically present in posterior mediastinum, the neuroenteric cysts. Even that is associated with hemivertebrae and spina bifida, is what you should remember. So there is a very popular theory called Bremer's theory of neuroenteric cysts. So there is one neuroenteric canal of Kowalski, and this canal is a transient physiological communication between yolk sac and the amniotic cavity. And any incomplete obliteration of this neuroenteric canal of Kowalski is responsible for the neuroenteric cyst presenting as a posterior mediastinal mass, is what you should remember. So typically it will show loculations on the CT and 2 to 10 centimeters, and it can present like a consolidation in the posterior lobe of the lung as a pleural effusion. Anything can be the presenting feature of this posterior mediastinal lesion, is what you need to remember. So you can see in the posterior mediastinum closer to the spine, the presence of the neuroenteric cyst is what you need to ultimately remember. Now, nocturnal enuresis, bedwetting. One of the great challenges a lot of parents have and the children have. So there are about 8 to 10 points you need to remember about nocturnal enuresis in pediatrics, one of the favorite topics of the examiner. So you should know that bell alarm system that is considered to be effective. Almost 2/3 of the children respond to the bell alarm system, and the relapse rate is lowest. So most successful therapy is the bell alarm system to treat the nocturnal enuresis is what I want to underscore to all of you. So how do you define nocturnal enuresis? At least twice a week bedwetting, at least 3 consecutive months in a child who is more than 5 years of age. So that is how you define nocturnal enuresis. Twice a week, at least 3 consecutive months in a child more than 5 years. Please don't forget, definition most of the times was asked. And primary means the child was never dry and he continued the enuresis. That is called primary enuresis. So wetting during the sleep, that is called nocturnal enuresis. Now the epidemiology. At the age of 5 years, 7% of boys, 3% of girls have enuresis. By 10 years, 3% of boys, 2% of girls, and by age 18, 1% of men, less than 1% of female has enuresis. So primary enuresis is found in about 85% of cases, and it's very common in the lower socioeconomic group. So what is the etiology? So basically, the bladder should detrusor, try to push the urine, and the sphincter will stop it and contain it. And any neurological immaturity can be the predisposing factor. Similarly, anxiety during 2nd to 5th years. Then ADH, circadian rhythms, they are very high at night and at 4 to 8 a.m. and that lead to enuresis. So they're all the etiological factors. But most of the times, only less than 5% of the kids who have nocturnal enuresis have an organic basis. And you should always rule out either any underlying UTI, like infection, proteinuria, glucosuria, that also can predispose to nocturnal enuresis is what you have to remember. So how do you treat? What age you should start treating is a very important question. So it should be started after 6 years. After 6 years. Caffeinated drinks should be avoided in the evening. Motivational therapy, alarm therapy, pharmacotherapy, etc., etc. So motivational therapy is successful in about 25% of cases. Alarm therapy is better after 7 years and successful in 2/3 of the patients. Then what are the pharmacological drugs that make the detrusor and the sphincter to live in coexistence with each other? So imipramine and anticholinergic drugs that reduce the uninhibited bladder contraction, like oxytocin, tolterodine, propyrin. So desmopressin will reduce the volume of the urine. But all these pharmacological therapies, relapse rate is very high. Yeah, is the voice is coming? Is the voice coming? Okay, voice is coming, but video is not coming and it is getting choked, right? So I think that should let us to live with it, right? I think that should let us to, yeah, just live with it, right? Just give me 2 minutes time, doctor. I'll try to reset internet and restart. Please be online. Yeah, I hope the internet will be better now. Yeah. So, resistant Plasmodium falciparum malaria in the pediatric age group. What is the best drug? Please punch your answers to this question, doctor. Clindamycin, clindamycin. So now let us run through the story of drug-resistant malaria and malaria as such. So how do you define drug resistance malaria? Resistance to 3 or more anti-malarials of 2 different chemical classes, of which 2 are 4-aminoquinolones and diaminopyrimidine. There should be resistance to these 2 classes. So why there is a resistance? Either because of longer half-life, poor compliance, host immunity, and single mutation for resistance. Most of the times it is a falciparum. More than 70% of cases, drug resistance are to the falciparum. So before that, let us quickly have a recap, doctor. This is the favorite area, whether you are in pharmacology, pediatrics, general medicine, obstetrics, gynecology, anywhere. You need to know chemical functional classification of antimalarials. 4-aminoquinolones, chloroquine, amodiaquine, piperaquine, they're all 4-aminoquinolones. 8-aminoquinolones are primaquine. Then folate synthesis inhibitors, sulfonamides like sulfadoxine and dapsone, biguanides, proguanil, diaminopyrimidine, that is pyrimethamine, they are all folate synthesis inhibitors. Then you have the cinchona alkaloids, quinine and quinidine. Lumifantrin and halofantrin are called amino alcohols. Then you have antimicrobials like clindamycin, azithromycin, doxycycline, tetracycline, fluoroquinolone, phosmidomycin. They're all antimicrobials. Then you have peroxides like artemisinin derivatives like artemether, arteether, artesunate, etc. Then you have naphthoquinones like atovaquone and iron chelating agents like desferoxamine. They are the various chemical classes of anti-malarials that you need to remember. Now, according to the mode of action, there is another classification that you need to batti marna padega. For the causal prophylaxis, you have to give the pre-erythrocytic schizonticides that kill the schizones in the liver. Like primaquine, proguanil, and tetracycline, these are all causal prophylaxis. Matlab, they will kill in the womb, that is pre-erythrocytic schizonticides. For the treatment of acute attack, you have to give erythrocytic schizonticides that kill the schizones in the blood. So here you have rapidly acting agents like chloroquine, quinine, atovaquone, artemisinin derivatives, and mefloquine. They're all rapidly acting schizonticides. Then slow acting will be proguanil, sulfonamides, tetracyclines, and pyrimethamine. So the drugs which are used for chemoprophylaxis typically will prevent the erythrocytes from getting infected. Similarly, for the radical cure, you need to kill the hypnozoids in the liver. To prevent the transmission, you have to kill at the level of the gametocytes. And for an acute attack, what is the site of action of the drug? So this is very, very important pictorial that you need to understand. Tomorrow's examiner is going to test you which level, which anti-malarial is acting. Favorite question. So if there is a chloroquine resistant falciparum malaria, then what is the recommendation? Artesunate 100 milligram twice daily for 3 days plus sulfadoxine pyrimethamine 1500 by 75 milligram 3 tablets single dose. Or you can give mefloquine 750 milligrams on second day, 500 milligrams on the third day. Then artemether 80 milligrams plus lumefantrine 480 milligrams twice daily into 3 days. Similarly, quinine plus doxycycline is another option for the chloroquine resistant falciparum malaria. So if you look at the various anti-malarials and their mode of action classification we are discussing, gametocytes prevent transmission. Exoerythrocytic schizonticides, which kill the hypnozoids, are used for radical cure. So primaquine is for the radical cure. You remember and take it as my word, doctor. One MCQ in malarial drugs अगर नहीं आए तो कल के नीट पीजी एग्जाम में मेरा नाम मुरली भरद्वाज नहीं है, बराबर? सो डेफिनेटली आने वाला क्वेश्चन है आपके 100 पेजेस नोटबुक में लिखना और मन में रखना और कल के एग्जाम में हमला करना. So what are the drugs that prevent transmission? Primaquine is effective to prevent transmission and gametocidal for all species. Artemisinin also for all. Quinine for vivax, chloroquine for vivax. It is gametocidal is what you need to remember. Similarly, there are certain special risk groups and how do you treat? This is another favorite very, very important MCQ in the tomorrow's NEET PG exam, doctor. I'm so happy to see 16 online classmates. So please tell all your friends, every day 6 p.m. I promise you to spend around 1.5 hour time up to 7:30 p.m. आप दुनिया में कहीं भी बैठो, कहीं भी रहो. Don't forget to switch on to the YouTube online MBBS channel, and you have Dr. Murali Bharadwaz spending 1.5 hour with you to do the revision for all you guys. So in the next 90 days, we are going to have 150 hours of live class, plus there is already 427 hours of HD video containing 1500 video lectures already available in the online mbbs.com video library. Then there are 30 full-scale grant tests and 10,000 MCQs as quiz tournaments for you to practice on the Incus app, and 10,000 PowerPoint slides of notes, high-yield notes. Everything is being made available for a small price of 10,000 rupees. So don't forget to take the best advantage of this. Please call our helpline 9000-868-356 and join today only. So doctor, first trimester of pregnancy में ഇവിടെ uncomplicated plasmodium falciparum quinine plus clindamycin for 7 days. Very strongly recommended combination. Infants less than 5 kg body weight, you need to use the artesunate, and patients co-infected with HIV, you can use, and one important point is, don't give the artesunate plus SP if they are already receiving cotrimoxazole. And if they are receiving efavirenz and zidovudin, avoid artesunate plus amodiaquin. So tomorrow's examiner is going to ask you, patients co-infected with HIV, how are you going to handle? Similarly, non-immune travelers returning to non-endemic settings, give artesunate. Then uncomplicated hyperparasitemia, so they should also receive artesunate. So you must be very sure. How do you treat uncomplicated falciparum in special risk groups? Now, doctor, the most common fetal response to acute hypoxia, what do you see? Bradycardia. What is the most sensitive indicator of the dehydration and intravascular volume contraction in infants? Always it is the heart rate. If the child is going into tachycardia, that is always an indicator of dehydration. Which intrauterine infection lead to limb reduction defects and scarring of the skin, doctor? Chickenpox, varicella virus. Cerebral calcifications and hydrocephalus, you see in the case of toxoplasmosis. Of all the vaccines, maximum efficacy. Today, COVID vaccine, we are talking about 94%, 90% efficacy. So measles vaccine has got the highest efficacy. What are the various nutritional assessment methods? If you have missed the yesterday's class, please take an opportunity. Still the video is there on the YouTube. How do you evaluate PEM? One of the favorite questions in the NEET PG. So birth weight less than 2,500, decreased weight for height, increased 1 to 4 year mortality rate. They're all the important indicators of malnutrition. A child with AML presents with hyperleukocytosis. 30,000, 40,000 count is there. If you start induction therapy, immediately there is a risk of tumor lysis syndrome. So alkalinization, allopurinol, IV fluid, they are all recommended, but you need to be careful to initiate induction chemotherapy. So Cairo and Bishop, they have given a definition for tumor lysis. Every time the tumor cell is breaking down, it leads to hyperuricemia, hyperkalemia, because they're all intracellular ions that become released into the plasma. Similarly, hypocalcemia, hyperphosphatemia, they are the Cairo-Bishop's definition of tumor lysis syndrome, which you need to remember. Whenever hepatitis B surface antigen is positive, so how do you want to give prophylaxis? Both the vaccine and also immunoglobulin. Polycystic kidney disease, it is autosomal recessive in childhood, not dominant. It can lead to pulmonary hypoplasia. Renal cysts are present at birth, and it can lead to congenital hepatic fibrosis, is what I want to underscore. A 7-year-old girl has generalized swelling of the body, grade 3 proteinuria, high lean and fatty cash, no history of hematuria. What does it all indicate? It indicates nephrotic syndrome. Nephrotic syndrome in pediatrics is due to minimal change disease. That is the reason there will be no IgG deposits or C3 deposition on the renal biopsy. A 5-year-old has precocious puberty. That means his testosterone is high. His blood pressure is also high. So mineralocorticoids are high. Testosterone is high, means 11-alpha hydroxylase deficiency associated congenital hyperplasia. So how do you evaluate 11-alpha hydroxylase deficiency? It is the deoxycortisol levels which become elevated in case of 11-alpha hydroxylase deficiency. Now, juvenile idiopathic arthritis, one of the favorite questions of the examiner. Uveitis, spikes of high fever, rheumatoid nodules, they're all the features. Achha, doctor, now I'm going to make you the experts in the topic of juvenile idiopathic arthritis. Whenever there is a chronic joint swelling, pain and functional limitation, at least 6 weeks. This is the favorite MCQ of the examiner. And why do you call juvenile? Because it starts before 16. There are some articular, extra-articular features. Joint swelling, joint pain, joint stiffness, joint warmth, limping gait, restricted joint movements. They're all articular. Enthesitis, wherever the tendons are inserting onto the bone, there is inflammation. Skin, growth disturbances, they're all extra-articular. So fever, pallor, anorexia, loss of weight, growth failure, delayed puberty, limb length discrepancy, subcutaneous nodules, and a rash. Hepatomegaly, splenomegaly, lymphadenopathy, serositis, uveitis, enthesitis, they're all the extra-articular manifestations of the juvenile arthritis. So there are 3 major types of JI: oligo, polysystemic. Polyarticular can be RF positive, RF negative. Also, you have enthesitis-related arthritis, psoriatic arthritis, undifferentiated arthritis. There are many other types. So, oligoarthritis, polyarthritis, which is RF negative, or RF positive, psoriatic arthritis, enthesitis related arthritis, they are all called undifferentiated arthritis. Now, one of the favorite questions of the examiner. How small you call it as oligoarticular? Typically less than 4. After diagnosis is oligoarticular. There are two types: oligoarticular persistent JIA, oligoarticular extended JIA. So typically oligoarticular juvenile inflammatory arthritis, age of onset is less than 6 years. So the mildest form of the JIA bole to oligoarticular. It affects females more, girls more than the boys. It often affects the large joints, uveitis. Rarely it leads to permanent joint damage. And if it is present beyond 6 months, you call extended type of oligoarticular. And that will affect both the big and the small joints. So this is how a affected knee joint in oligoarthritis. Poly bole to 5 or more joints. Oligo means 4 or less. Poly means 5 or more. It can be rheumatoid factor positive or negative. If it is rheumatoid factor positive, it presents between 6 to 7 years. Rheumatoid factor negative will present between 9 to 12 years. So polyarticular is more common in the people more than 10 years of age. Once more common in the females. Then those who are rheumatoid factor positive with polyarticular type, they have rheumatoid nodules, anemia, fatigue, poor appetite, a general feeling of being unwell. If it is RF negative, polyarticular, female more than male, it starts in multiple joints at the same time. Then finally comes the systemic arthritis. Commonly, the age of onset is 2 to 4 years. Boys and girls are equally affected in systemic arthritis. Usually, there is a spiking fever, which rapidly rises and rapidly falls back. And there can be pale pink red spots on the chest, swollen lymph nodes. After the fever appears, arthritis will start within 6 months. And there is a hepatosplenomegaly in systemic arthritis. So this is how the skin rash of systemic arthritis. The skin rash of systemic arthritis. Then finally, enthesitis related arthritis is between 9 to 12 years. And this is more common in the males than in the females. So, oligoarticular, polyarticular, systemic onset, and spondyloarthropathies. How these 4 among the JIA and what are the differences between them? Sure, short MCQ in tomorrow's NEET PG Topper. Be very sure. Now, neuroblastoma, what is true? Neuroblastoma lead to bony metastasis. It is the most common extracranial solid tumor in childhood. More than 50% present with metastasis at the time of birth. And it will often encase the aorta and its branches. Day before yesterday's evening class, we discussed differences between Wilms tumor and the neuroblastoma. You have to be 100% sure. Neural tube defects, acetylcholinesterase levels is a very important marker. Now, A child under 5 years of age is often affected with malnutrition, low birth weight, infections, etc., etc. A 10-year-old comes with seizures, blood pressure is high, 200 by 140, femoral pulse is not palpable. Many times we discussed. What is your diagnosis? Keep punching the answers, doctor. Coarctation of aorta. A 7-year-old asymptomatic girl has persistent hypertension, but urine examination is normal. What could be the cause? Renal parenchymal disease is one of the important causes of the hypertension in case of the pediatric population. A child presented with left flank pain, large hydronephrosis, dilated renal pelvis, cortical thinning. So you have the kidney, doctor. Kidney ke andar kaun hota hai? Pelvis. And here you have a ureter. Entire ureter is normal. That means pelvic-ureteric junction, PUJ. In some people, congenitally, PUJ is narrow. Such people will end up in hydronephrosis. And you have to treat it by doing pyeloplasty and repairing the uretero-pelvic junction obstruction is what you should remember. A child has hepatomegaly, hypoglycemia, no improvement on sugar after giving glucagon, epinephrine, etc. So that is a clue to say it is type 1 glycogen storage disorder, which is von Guy's disease. Yesterday we have discussed this question. A lot of times after the febrile seizures, while going home, the child's parents will request you, doctor, is there any chance of my child building epilepsy? What's your answer? So you should remember, doc, that if the seizures at the time of febrile seizures, if they are complex, loss of consciousness, any developmental anomalies are there, or if there is any positive family history of epilepsy, then only febrile seizures may lead to epilepsy. But otherwise, they don't lead to epilepsy. A child has vacant stare. That's enough. What is your diagnosis? Absent seizures. Juvenile myoclonic epilepsy. Typically, the child will be going into sudden run of myoclonus and loses the tone. That's called salam spell. So they should be treated with topiramate, genisamine, and valproate. So doctor, please don't forget to go back to the onlinemmbbs.com 427 hours crash course. In that 50 hours beautiful video we have discussed entire pharmacology. In that you need to take revision of the anti-epileptic drugs topic after this session is over. Okay, that's what you are promising me. A child presented with a neurocutaneous syndrome with multiple hypopigmented macules. What is your diagnosis, doctor? Tuberous sclerosis. So whenever tuberous sclerosis is there, typically they present with hypopigmented macules. Meningoencephalitis in children, most commonly virus, and that is enterovirus. Recurrent meningitis in a kid who has CSF leakage. It is the capsulated organism like pneumococci which are responsible. A 2-year-old is having a purulent nasal discharge, conjunctival congestion, and opacification of ethmoid sinus. So always CT scan will give you a good delineation and the imaging of the paranasal sinuses and the pathology. A boy presented with a weakness in lower limbs, calf hypertrophy, Grover sign positive, elevated CPK. Oh my God. What else do you need? Dukeen's muscular dystrophy. Scurvy may. Why the bone get affected in scurvy? Why vitamin C is required? Vitamin C is required for the osteoid matrix formation. Once that is not there, then the osteoid is no more mature. And that lead to all the bony problems in scurvy is what you should remember. At 38 weeks of gestation, with a birth weight of 2.2 kilos, sepsis screen is negative, but PCV, packed cell volume, is 72%. So that is a classical story of polycythemia, which is treated with partial exchange transfusion. So what is the normal PCV, doctor? Between 45 to 65% and hemoglobin 15 to 25. And the term infant will have around 35%. So whenever polycythemia is there, the infant has got neurological signs like jitteriness, convulsions, poor feeding, respiratory distress, hypoglycemia, heart failure, then it should be treated with partial plasma exchange therapy is what you should remember. Which is the earliest indicator of a gastroesophageal reflux. When a gastroesophageal reflux is there, that leads to development of respiratory symptoms, classically. An infant of a diabetic mother with a weight of 3.8 kgs presented with seizures after 16 hours of birth. So all the list of complications in the babies born to the diabetic mother, you have to do the revision, doctor. So hypoglycemia, hypocalcemia, any of them in fact can lead to the development of seizures after 16 hours of birth. Pentalogy of Fallot, additionally you have atrial septal defect. So how do you differentiate ASD from VSD? Very, very easy question. How do you differentiate ASD from that of the VSD? Suppose VSD is there, doctor. What will happen? Left ventricular blood will go into right ventricle. Right ventricle blood increased flow into pulmonary artery, increased flow into pulmonary vein, increased flow ultimately into left atrium. So that is the reason left atrium is enlarged whenever there is a VSD. Whereas in ASD, left atrium is pushing the blood directly into right atrium. So left atrium has no work at all in ASD. That is the reason left atrium does not enlarge in ASD, but left atrium enlargement is a feature of VSD is what you should remember. A previously healthy infant presents with recurrent episodes of abdominal pain, altered stool after episodes of pain, no history of vomiting or bleeding per rectum. So typically is a case of intussusception is what you should remember. A 12-year-old boy, Mrs. Melina, splenomegaly, all signs of portal hypertension. But there is no jaundice, no ascites. That means it is not because of cirrhosis. It is not because of cirrhosis. It is because of extrahepatic portal vein obstruction, which is the most common cause for the development of the portal hypertension. In case of pediatric population is what you need to remember. A child presents to emergency department with respiratory distress. There is a fever, there is a wheeze, there is an exaggerated breathlessness. And function tests, pulmonary function tests show obstructive pattern. What is your diagnosis? bronchiolitis obliterans is what you need to remember. What is the most common tumor that you see? Neurofibromatosis 1. Juvenile myelomonocytic leukemia, JMML, is commonly seen, the most common tumor associated with neurofibromatosis type 1 in a child. What is the most common cause of meningoencephalitis in children? Enterovirus. A 6-year-old managed it. You have removed craniopharyngioma, but in the process you have disturbed the pituitary, etc. So multiple endocrinopathies are there. So when you want to do the replacement hormonal therapy, what is the best hormone to start first? So it is the hydrocortisone that should be replaced first, even before you think of giving the growth hormone or anything. A 1-year-old child has short, constipated, palpable goiter. TF, elevated TSH, what is your diagnosis? So, low T4, elevated TSH simply means hypothyroidism, right? So, typically, hypothyroidism is because of the thyroid disharmonogenesis in case of pediatric population. In an 8-year-old male infant, there is a hyperpigmentation of the genital skin. 8 days old, very young. Then blood reveals sodium 125, hyponatremia, and potassium 7, hyperkalemia. That means hypoaldosteronism. So aldosterone is low, testosterone is high. What is your diagnosis? 21 alpha hydroxylase deficiency, congenital adrenal hyperplasia. So what are the various causes of ambiguous genitalia in a female child? If you take this 4, aromatic deficiency, CAH, development 14, they are all the ones. The logical classification, you need to be quite sure of the ambiguous genitalia, where the androgen exposure or a deficiency of testicular hormones, any of them can be implicated as a cause of the ambiguous genitalia in the pediatric population. So, doctor, with this, we reach the end of the story of the today's wonderful evening. I hope you all get that required energy to open up pediatrics. We will have a discussion till Sunday. We will try to finish around 540 MCQs are there in pediatrics. The most high-yield ones, almost half of them we are done, already 250 questions. Still we have Friday, Saturday, Sunday, 3 more days. We will try to finish all the things, and every week we will pick up a new subject and then move forward. But listening is not sufficient. Attending this online live session only should inspire you. You need to bring out the best out of yourselves and then go back and do the revision on the onlinemmbbs.com video library. See you once more tomorrow at evening 6 o'clock. Let us study together every day and become better and confident. And this is a God-given opportunity. March, 3rd week entrance exam getting postponed. Even today you start the preparation. I'm sure you are going to be the winner. Okay? Thank you very much.